Ladies and gentlemen, welcome to the 10th International Breastfeeding and Lactation Symposium of Medela, which takes this year place in Warsaw, Poland. We are very pleased to be here. We chose to go to different countries just to talk about the topic of breast milk feeding, and we are very happy to be in this country where Medela has also a subsidiary. I welcome all you here, our guests in the Sheraton Hotel in Warsaw, but I also welcome all of you out there somewhere on a screen who have linked into our website and are now following the live broadcast via the internet. Medela has organized this symposium for 10 straight years, so it's our 10th anniversary, so to speak. We organized it first in Basel, then in Düsseldorf, over to Manchester, Angers in France, then Venice, Amsterdam, Vienna, Copenhagen, last year in Madrid, and this year in Warsaw. Today, here in Poland, we expect about 450 guests from 48 countries who will listen to presentations of 9 speakers, whom I will present to you later on. They will listen to presentations that are dealing with 3 major themes. They go around latest recommendations for research-based practice. Another topic, the unique components of human milk. And a third topic, the value of human milk in the NICU, the neonatal intensive care units. During this media conference that we are all attending right now, we may use the question function on the screen. Those who are watching us right now, please type your questions into this, the screen. Sounds weird. Just write your questions down. We will have a computer here, read them loud in the room. I want also you here in the room encouraged to put some questions down while you were listening or listening to the speakers so that we have an intense exchange afterwards. So let me welcome all the speakers today. Professor Donna Geddes from Australia, Anna Cannon from Australia and Poland, Foteni Hasiotu from Australia, Maria Wilinska from Poland, Professor Cindy Lee Dennis from Canada, Matthias Keller from Germany, Christoph Fusch from Germany, Diane Spatch from the US, and Professor Shu Li from Canada. And I don't lose many words anymore, so I hand over to short presentations of the topics that we will be presented during the next 1.5 days. And I want to start with Professor Donna Geddes from Australia, from the University of Western Australia, who gives us an insight to her topic, appetite regulation of breastfed infants. Thank you, Donna.
Thank you, Martin. So I'm presenting some work that revolves around a central theme in our lab where we're trying to understand appetite control regulation and the effect that has on the growth and the body composition of the breastfed infant. So we're essentially looking at how the baby's developing and how that will influence its later health. So there's a lot of evidence to support the notion that early environment for both the fetus and the infant has a programming effect, and it affects how healthy they are later in life. For instance, if a mother gains a lot of weight during pregnancy, she's likely to have a heavier baby. That baby's likely to be predisposed to become obese. And similarly, in the days after birth and to 2 years of age, nutrition provides an opportunity where there's plasticity and programming occurring that also affects our later health. So it's believed that developmental programming occurs in this period, and to do with appetite control, we have the perfect situation of control. So between the mother and the infant is essentially directing and satisfying its own appetite on demand. And the process works beautifully until we start weaning the infant. So what we'd like to do is understand exactly how that programming takes place, what factors influence it for the breastfeeding infant, and that should allow us to intervene or promote practices that are beneficial for the infant. So, for example, I'll be presenting today about the factors in breast milk that affect breastfeeding frequency and behaviour. For instance, we've found that protein and lactose do so. They have associations with the way the baby feeds. We're also looking at the newly discovered appetite control factors that have only been around for maybe 5 to 10 years, and they're actually actively made by the breast and secreted into the milk and work on the baby. But not only do they control short-term appetite, they have multiple functions. For example, one of those functions for leptin is to control development of the breast or be involved in cell proliferation and differentiation. So we'll present some data on those, and then a largely ignored piece of our physiology, if you like, is gastric emptying. It's difficult to study in infants, but it's also a key regulator of appetite. So how does the milk affect gastric emptying in both the term and the preterm infants? And indeed we find that it does. And does volume affect the rates of gastric emptying? So basically what we're doing is we're putting all of these studies into a longitudinal study of breastfeeding infants to see how that affects their growth and their body composition. So we're hoping to understand that, and once we understand that we can give to the clinicians and provide them some information about how they might manage difficult babies.
Thank you very much, Donna. Anna, you deal with the protein, if I'm right, leptin, and you will explain whether I'm right or not, and what is the influence of this leptin in breast milk for the baby. So I hand over to you.
Thank you. So my area of interest of research is looking into appetite control hormones, and these hormones stimulate our appetite and our feeding behaviors. And leptin, this is something I was looking in particular, was first discovered almost 20 years ago, and that generated a lot of interest into the field. So like Donna said, there are more appetite control hormones that are out there, and all of them are present in the breast milk. So with the research I was doing, we were looking into how leptin is affecting breastfeeding patterns, how that affects baby, how it affects gastric emptying of the infants. A lot of the studies that are done, a lot of the information that they provide, they're usually done in adults, and we cannot extrapolate results from the adult studies into infants. So we're looking at getting some more information how the appetite control is stimulated by leptin.
Now I had to learn that among proteins and hormones, we have also an unbelievably big number of cells in breast milk that serve multiple purposes, and one of those cells are stem cells. So Foteini Hasiotu has been our guest before. She has published about stem cells in human milk, and I'd like to ask her whether there are new insights on what stem cells do in a baby's body after they have come into the baby via the milk, to say it simply.
Thank you, Martin. It's been a pleasure to be part of this conference again this year. And over a century now, for over a century, we know that breast milk contains cells from the mother, maternal cells. But it's only in the last few years that we discovered that some of these cells are actually stem cells. And what is more, we know that there is a whole cellular hierarchy in breast milk, from early stage stem cells to progenitor cells and more differentiated cells that we find in the human lactating breast. So what I'm going to do today, later on in my presentation, I will try to give you a summary of the current knowledge about the cells in human milk and put more emphasis on the stem cells and what we know about these cells. First, where they come from, the lactating breast, how we can use them to understand the biology of the breast, how the breast remodels during pregnancy and lactation to become an organ that can synthesize and secrete breast milk to the baby. I will also show you some data about the properties of these cells themselves, the fact that they have multi-lineage potential, that they're able to turn into many different cell types, not only breast cells, but also bone cells, joint cells, fat cells, brain cells, liver cells, pancreatic cells, and other cell types. I will also then discuss how we can use these cells for understanding not only the biology of the lactating breast, but also pathologies of the breast. For example, in women with low milk supply, which is an issue that's quite prominent in women that give birth preterm. And what we can understand by looking at these stem cells in terms of what goes wrong in the breast of these women that they cannot produce enough milk. I will also discuss how we can use these cells to understand other pathologies of the breast, such as breast cancer, and what goes wrong in the breast that leads to cancer, and then how we can successfully treat it by looking at what goes wrong through these cells in breast milk. I will these cells after they're ingested by the baby, and that's an area that interests me the most, and I think it's very, very important because for the first time we are showing that these cells are able to actually survive in the baby's stomach, get into the blood circulation, and then go into different tissues and different organs where they are able to integrate and become functional, potentially providing important developmental benefits for the baby. Finally, we'll also provide some ideas and discuss a little bit about other potential applications of stem cells in breast milk outside of the field of lactation, for example, in regenerative medicine, and how we can use these stem cells to treat diseases of babies, but also of adults.
Thank you. Dr. Maria Wilinska is a doctor. She works in a hospital. She knows a lot about women who like to breastfeed, women who may face difficulties while breastfeeding. We are very happy to have her here as a representative of Poland specifically. Please describe to us what kind of programs you have implemented in your hospitals to help women.
Thank you very much. Do you allow me to say this in Polish, not in English? Bardzo mi miło, że mogę.
Ladies and gentlemen, it's a pleasure to show you the results of implementing the programs supporting exclusive breastfeeding for preterm infants. I work in the NICU at the Orłowski Memorial Hospital in Warsaw, and for 3 years there's been a possibility of feeding our patients exclusively with human milk. It was possible thanks to the program of training medical personnel in supporting lactation, i.e. the medical personnel was trained on what to do in order to trigger good lactation in mothers of the babies we treat, thanks to the joint work of the neonatal and maternity unit. And the vast majority of cases, lactation is triggered at the level that is enough for the mother to exclusively feed her child with her own milk. In some situations where the mother is not there or there is not enough supply, it is possible to supplement with the milk from the human milk bank. For the 3 years I've been working on that, we've created such a human milk bank in my hospital. Thanks to this, there is no situation where we use formula milk in feeding preterm infants. Thanks to this system, we completely altered the clinical results of treatment of our babies. Exclusive human milk feeding has lots of benefits, finance-wise also, for the hospital, and this is what we are trying to tell our decision makers and our authorities, i.e. the Ministry of Health. Every year we give them information about the results of our work. However, the paramount thing is the health of our babies. When it comes to the clinical results of treating premature babies, we remarkably decreased the morbidity, and we managed to prevent very serious conditions affecting the preterm neonates, predominantly necrotizing enterocolitis. Thanks to our program, central venous lines stay for a shorter time in the babies. Also, there are fewer hospital infections. There's smaller use of antibiotics. It all translates into lower cost of treatment. Also, it positively affects sociological costs. Safety and security feeling in mothers is enhanced because mothers are part and parcel of the therapeutic process. Also, there is a good space for fathers. It is not the doctor, not the nurse, but the parents who are the main beneficiaries of this system of caring for infants. Thanks to such a high dedication and such a high contribution from parents, from the very start, they are treated as the paramount element of therapy of the children. This is a total shift of mentality and concept of treating babies, and we are going to dwell upon that because the results are really exquisite. So we are going to spread this concept across other hospitals in Poland too. We are trying to make the early lactation program initiated by our national neonatology consultant, Professor Helwig. We'll try to spread it all across the country, and I hope that this program will be widely accepted, and I hope it will be promoted and universally used in all hospitals in Poland.
So, she's got a 3-year program she undertook to foster breastfeeding in the hospitals she is working. She notices that this is a big success with parents because they can be involved much earlier. It's a big success cost-wise because people are less time in hospital. It is better for them in later life. And she hopes that this program that she has really pushed through brings the respect or gets acceptance by the hospitals, by the government, by the parents, by the mothers. So the topic is breastfeeding, the most important thing already in hospital at the beginning of the baby's lives. And exactly this topic is one that Professor Cindy Lee Dennis has dealt with very intensively. So would you please give us a short insight on what you are doing in this respect?
Good morning. Thank you for having me here today. My talk tomorrow is going to be on promoting exclusive breastfeeding, current evidence-based practices, and future ideas that I have that I think we can implement to promote exclusive breastfeeding. The World Health Organization recommends that all babies be exclusively breastfed to 6 months of age. This is based on very strong evidence that exclusive breastfeeding decreases mortality rates and morbidity rates. Exclusive breastfeeding is one of the most health-promoting, disease-preventing activities that a mother can perform. However, only 38% of mothers around the world exclusively breastfeed their babies to 6 months. The reasons for this are very diverse. Societal beliefs favoring that mixed feeding, such as introducing supplements or other foods, is more beneficial than just the mother's milk alone. We have hospital practices that are not supportive of breastfeeding. We lack skilled individuals in the community to support mothers once they're discharged home from the hospital. We have aggressive promotion of infant formula. We have inadequate maternity leaves and workplace policies, so when mothers do have to return to work, that they should be able to continue to breastfeed. And also we have a lack of knowledge around the dangers of not exclusively breastfeeding. What we need is comprehensive, evidence-based, at-scale programs that are tailored to the local context. So what may work here in Poland may not necessarily work in Peru or in Canada. But what we do know is that we need strategies at all levels. We need strategies at the health system level, at the community level, and at the policy level. At the health system level, we can implement things like the Baby Friendly Hospital Initiative, which was developed by the WHO and UNICEF. And this includes 10 steps to successful breastfeeding, so that we can ensure that the majority of mothers go home exclusively breastfeeding. But once they're home, we also need to have community-based policies and strategies. And this will incorporate long-term support. And I think the best support that we can provide to mothers is mother-to-mother type of support, where experienced mothers who themselves have actually exclusively breastfed to 6 months support new mothers to encourage them and provide appraisal support so that they can continue to breastfeed exclusively. At a policy level, I think that we need to be promoting maternity leaves. It's really unrealistic to expect mothers to exclusively breastfeed to 6 months when they have to return to work at 6 weeks postpartum or up to 14 weeks postpartum. We need to educate mothers that you can continue to breastfeed when you do return to work, and there are certain policies that can be put in place for that. Lastly, we also need to educate companies that having policies around exclusive breastfeeding is good for them. It increases morale, it decreases the absenteeism within mothers, and it's also good for the company's image. I also think that we need a social marketing program. We've done a very good job at promoting the benefits of breastfeeding, which has increased breastfeeding initiation rates around the world. However, we have not done a very good job promoting exclusive breastfeeding. Mothers think that any breastfeeding is just as good as exclusive breastfeeding, and it's not the same. The health benefits are not the same. So we need some social marketing campaigns around that. Future ideas that I have as to what we can further develop to promote exclusive breastfeeding include breastfeeding self-efficacy. So strategies to increase a mother's confidence in her ability to breastfeed. We know that mothers' number one reason for discontinuing breastfeeding time and time again is that they perceive that they have insufficient milk. That is directly related to a mother's confidence in her ability to breastfeed. We also need to involve fathers. Fathers are very influential in infant feeding decisions. And I think that we need to start exploring co-parenting frameworks. And lastly, I think we need to be aware of postpartum depression. My research clearly shows that if a mother is experiencing postpartum depression, she is significantly more likely to discontinue breastfeeding by 8 weeks postpartum. So that is a summary of what my talk is going to be about tomorrow. Thank you.
Thank you. She spoke about fathers. Probably my parents, the father was not allowed to be present in the room when I was born. When I had kids, I was at least admitted to the room where my boy was born. But the tendency goes into a direction that father, mother, family are very much involved much longer after birth. And I assume that Matthias Keller is giving us some insights when he speaks about programs for family integrated care, how this is done today.
Thank you very much for being here in Warsaw. It's a great pleasure. And let me start with a very provocative message. And the message is, baby needs their parents and the parents need their babies. This is a statement which is normal for parents because, of course, I want to be with the baby. However, for parents of sick newborns and of parents of preterm born infants, this is not something normal. The preterm birth is not a rare disease. About 1 in 10 babies are born preterm. About 1 in 7 babies are admitted to a NICU. And this means for the families a separation of the newborn. It means a separation of emotion challenges. It means an increased rate of postpartum depression. Cindy already mentioned the importance of postpartum depression for breastfeeding. But it's also important that we know that the early attachment to the child, the parental attachment and the parental bonding impacts the long-term outcome of our preterm infants. So it's not only that human milk is one of the best and important factors to increase survival of the preterm infants, it also by supporting the family that we know that we can increase the survival of preterm born infants, but also the neurological and behavioral outcome. However, current medical strategies are not taking into account the family as it should be. So which means we have enough knowledge that families are an intriguing part of an excellent neonatology. However, we have a lack of translation of this evidence into clinical practice. Therefore, we need a change management. And change management is not something which happens just by accident. So we need so-called clinical care programs in which we are aware of the effect of families and where we create indicators and measure indicators of the effect of the families being present in our NICUs. The last 3 years we have developed a so-called multidisciplinary program for family integrated care. It's a clinical care program which starts taking care about the whole family prenatally by admission of the hospital until discharge and caring the aftercare. What we have demonstrated, and I will show the data tomorrow, that by integrating and supporting the family, we reduce mortality, which means less baby die. We reduce the rate of infection, and this is just the opposite what was done in the past. Most doctors nurses were afraid that the parents being present in the NICU will introduce infections to the babies, and the babies are at risk if the parents are there. However, it's just the opposite. When the parents are allowed to stay with the babies and are part of the therapeutic pathway, we have demonstrated a reduction of the length of stay in the hospital, so they get earlier home. They have a reduction in sepsis rate and infection rate. And what is even most important, that we have a reduction of the readmission rate. So which means the babies are much more healthier and the parents are much more confident in taking the baby home. So in summary, I think in future we cannot neglect that family integrated care is an intriguing and essential part of good neonatal care. I can just support that we need strategies on the local, national and political levels to endorse family-centered care, because this is one of the best investments which we can do to prevent behavioral deficits in our infants. Already 2003, the Nobel Prize laureate Heckman has shown and demonstrated that each euro which we invest in an early period of life is of much more benefit to the society, so which means we get much more return to society if we invest earlier in the lifespan. Therefore, I think there's enough reasons for change, and we hope that with this program we can help families and help the preterm born infants.
Thank you very much, Mr. Keller. You know, I feel reminded to one statement in this conference in Copenhagen, where Professor Uwe Ewald from Uppsala in Sweden said, "Today's incubator for premature babies is not this machine anymore, it's the chest of mother or father." And I was new to Medela, but that was a really impressive statement because it showed me the switch or the change in the perception, how to treat premature baby. There's another point I had to learn when I joined Medela. We speak about the value of breast milk and how this is, we heard it before, the one thing that you should give to babies. Now I had to learn that premature babies have extreme needs for their growth. They grow much faster than normal born babies. And I learned that fortification, that means to add something to this milk in favor of the growth of the baby, is not only evil. So, Christoph Fuchs, give us an insight on what we should think about the modern ways of fortification of human milk.
Thank you very much. Thank you very much for the invitation here to Warsaw. I enjoy a lot being here. Maybe just for my affiliation, I'm working in Canada. I'm a Swiss and German trained hands-on neonatologist and researcher, but since 7 years I worked in Canada, sometimes together with Julie. So there is a theorem for preterm babies that they should grow according to fetal growth rates. And fetal growth rates for very tiny babies that are being born at 24, 25, 26 weeks are much higher compared to term babies. And it's a factor of 3. And breast milk, which is absolutely the best product that we can give to babies, has been invented by Mother Nature to make term babies grow the right way, but not preterm babies. So we are running into a deficit if we give babies only breast milk. This milk is too thin. It's not rich enough in nutrients. So in the last 20 years, human milk fortifiers have been developed, which are unfortunately cow's milk based and not human protein milk based, which causes some other problems, but to enhance the nutritive value. But that doesn't fix the variation of breast milk. Breast milk is not a standardized product. Breast milk, and that shows our research and research of others, has a huge variation and contributes most likely that part of the babies, though they are being standard fortified or the breast milk is standard fortified, do not grow very well. A baby that does not grow very well during the NICU time comes into a deficit with everything. Mainly with brain growth, and that might translate in later intelligence and brain function. So we have devoted a good part of our research in the last few years to try to measure breast milk content basically at bedside and to develop strategies to individualize fortification. It's a little bit of work, but we could show that growth becomes predictable for these preterm babies and that we have less or basically no postnatal growth retardation anymore. So babies start to grow according to fetal rates. And in future, we would like to work on finding the right components, ideally human milk-based, to try to eliminate all kinds of cow's milk products, and to find also some proof what is really the right growth velocity and where do we have babies to grow in the huge variation according through the percentiles.
Thank you very much for this.
Dziękuję bardzo za to wyjaśnienie. W szpitalu często mam do czynienia z bardzo chorymi niemowlętami, a wiemy, że mleko ludzkie zawiera wiele składników o dużych wartościach immunologicznych, odpornościowych. Dlatego też mleko ludzkie dla dzieci chorych wydaje się być najlepszym możliwym lekarstwem. Natomiast stara, tradycyjna medycyna zawsze zaleca podanie lekarstw i ewentualnie mleka modyfikowanego czy mieszanki. Diane, w jaki sposób opracowujecie program, który pozwala na zapewnienie mleka ludzkiego również tym najbardziej chorym niemowlętom?
I'm a PhD nurse researcher and the director of the Lactation program at the Children's Hospital of Philadelphia. I must first start by saying that in the United States, a mere 79% of women start breastfeeding their children, and less than 20% of infants are exclusively breastfed for the first 6 months. Furthermore, as mentioned by Cindy Lee Dennis, less than 40% of babies around the world are exclusively breastfed for the first 6 months. Critically ill babies are at even higher risk for not receiving human milk. And research demonstrates that these are the babies that need the milk the most. In the United States, research from U.S. NICUs shows that on average, only 44% of infants are discharged on human milk. The Children's Hospital of Philadelphia is the #1 children's hospital in the United States. We have a 100-bed neonatal intensive care unit where we care for the most vulnerable of infants, not only infants who are born preterm, but also infants with complex congenital surgical anomalies. Many of our infants undergo in utero surgery or have surgery immediately following their birth, and they must start their life with a several-month NICU stay. Tomorrow, I will speak about 2 innovative models of care that I have developed at the Children's Hospital of Philadelphia, which have resulted in human milk and breastfeeding initiation and continuation rates that are statistically significantly higher than US data. These 2 models are the Breastfeeding Resource Nurse Program and the SPATS 10 Steps model for promoting and protecting human milk in breastfeeding for vulnerable infants. The Breastfeeding Resource Nurse Program provides bedside nurses with the knowledge and skills necessary to provide expert, evidence-based lactation care and support. The 16-hour course focuses on the provision of human milk and breastfeeding in the context of maternal-infant separation and critically ill children. At Children's Hospital of Philadelphia, we have over 600 of these nurses who provide direct breastfeeding assistance and support 24 hours a day, 7 days a week. The SPATS 10-step model starts with a focus on informed decision and the initiation and maintenance of milk supply. Mothers and their families must understand the critical importance of human milk as a medical intervention, even if they never had the prenatal intent to breastfeed. Furthermore, we must provide mothers with the knowledge and tools to initiate and sustain milk production long term. We also have our parents engaged in human milk oral care, which has been demonstrated to be a strong motivating factor for mothers to keep pumping and build their milk supply, even if their infants cannot yet receive enteral feeds. At the Children's Hospital of Philadelphia, 99% of our mothers initiate pumping for their critically ill children. Over 86% of our infants are discharged on human milk and breastfeeding. And our mothers breastfeed on average for 8 months, with a range up to 30 months. Implementation of my model at the Tampa General Hospital resulted in a 3-fold increase of human milk at discharge. And in Thailand, they are currently implementing this model countrywide, with some NICUs reporting an increase in human milk rates at discharge 5-fold, only in a 1-year period of time. These models are evidence-based that are cross-culturally and internationally transferable, leading to improved human milk and breastfeeding outcomes, both short and long term. And this is what I will be addressing tomorrow.
So we heard about programs that are structuring the way how human milk is given to babies. Professor Shu Lee was our guest last year already and described ways how human milk was used to fight one of the worst illnesses babies can get, NEC. And he described ways that were surprisingly simple, so to speak, and were very effective. And I assume that you're going into this topic again.
Thank you, Martin. So my work revolves around how do we improve outcomes for babies. And I look at it from the point of view of clinical care as well as health service delivery and policy. I'm a neonatologist and health economist, so I count beans, as some people say. In Canada, I lead a nationwide effort to improve the outcomes of babies using information that we already know, as opposed to trying to find new treatment methods. And over the past 10 years, we have significantly improved outcomes across Canada by about 1/3 for all very low birth weight infants admitted to any NICU in Canada. So currently, for example, we have improved the outcomes of babies such that 10 years ago, about half of all very low birth weight infants admitted to the NICU had some degree of complication. Today, 75% of babies admitted to any NICU in Canada have no complications at all anywhere during their lifetime. So that's a significant improvement. Now, during this conference, I'm going to be speaking about two things specifically. The first is our efforts to try and reduce necrotizing enterocolitis using very simple methods and based around breast milk feeding. In fact, over the past 5 years, we have decreased necrotizing enterocolitis in Canada by half. And we think that we can go even further over the next few years. The second thing I'm going to be talking about is actually something called family integrated care, which is actually a very different model from our previous speaker. This is a model of care where we are using parents as primary caregivers instead of nurses. They replace the nurses in the NICU. And they provide all the care for the babies with the exception of IV and procedures. And this has resulted in dramatic improvements in growth, in breastfeeding rates, in infections, in parental stress, and in overall outcomes for all the babies. And this particular model of care, in fact, was written up just this week as a feature article in the Wall Street Journal. And we are conducting a multi-nation, multi-center trial currently on this. It will complete in the next few months. And if it's successful, will become standard of care in Canada and several other countries by next year. So this is another effort to improve breastfeeding rates and to improve parental care for babies. And we think that this is a new paradigm shift that will be very widely adopted around the world very soon, because many countries are now trialing the same method that we are doing.
Thank you very much, Shuli. We have heard 9 short, comprehensive summaries. I would believe that not everything can be clear after these short introductions, so I may encourage you here in the room, I may encourage you out there at your screens to use the facility to ask questions. You can ask them in Polish or in English. We try to make it happen that both languages are respected enough. So whom may I give the word through the microphone for the first question? It's rare in times where the web is so fast that we take time, but I will. Kim, can you ask one question you received?
Sure, we actually have a couple. Can you hear me okay? Excellent. Professor Pusch, do you see individualized fortification as the wave of the future? Will it or should it be the standard? And what are the barriers?
Yes, thank you. This is a relatively new concept. The concept is old, has been identified already 20 years ago, but has never been put into practice. And it's a little bit of work to implement it. Though, and we think it works very well, so that it might become hopefully a standard practice in the future. Just right now we are looking, do we really need to measure every day breast milk content? We found it's not necessary. We might need to measure it only once per week, which reduces workload a lot. So it's a lot about all these parameters, whether it becomes a practice that can be easily adopted or might take some time. The more obvious it becomes that it directly translates into better care or less costs, the faster we will adapt it. I personally think it will be the right way for those babies who will not grow, at least to measure.
Thank you.
Questions? I have another one for Maria Wilinska. You spoke about the value of the programs to increase breastfeeding. What were your most 3 important arguments to convince mothers or your hospital managers to go this route?
Trzy najważniejsze
three main arguments to convince mothers and hospital managers to implement a breastfeeding promotion program. The first and foremost clinical criterion is the health outcome for the baby. It matters most to parents, so better health of children should be the paramount argument for both parents but also healthcare decision makers, because expenditure on treatment of the babies later on in life, when they are no longer babies, will be smaller. We know that health is shaped in the first days and weeks after birth, especially in preemies. The healthier the baby is, the fewer complications they have, the smaller health expenditure on them in the future. To parents, it matters a lot to be involved in the therapeutic process because it decreases the stress level. Preterm delivery is always a destructive and disruptive phenomenon. Mothers are not prepared for that. They are very stressed out, and including the mothers through the presence and taking and using the breast milk in the therapeutic process of the babies, treating breast milk as part and parcel and a precondition for the therapeutic outcome, allows to make the presence of mothers in NICUs more real, kind of. It alleviates the stress, and it allows for the mother and the father to be part of the care process from day one. Just like the previous speakers stressed, a father is a very important person in the process because the father then can feel the head of the family from day one. And the third argument for hospital managers possibly is that we should work in full accord with our hospital managers. And the paramount argument is that exclusive breastfeeding is pure economy for hospitals. Not only in terms of spending less money on formulas, but also decreasing the treatment costs, decreasing the length of stay, decreasing the spendings on antibiotics or parenteral nutrition, shortening the treatment time. So financial aspects should be very convincing to hospital managers, I think. And one more thing, according to WHO and all scientific societies, breastfeeding is a recommended way of nutrition in babies and infants in Poland and globally. The Ministries of Health and governments signed many years ago a program of commitment to implementing breastfeeding of infants. So this is a commitment, and I think natural breastfeeding, natural feeding of children and infants staying in hospitals and then later on in life should be treated as commitment too.
So Maria spoke about the importance that fathers, families are involved early in this process, besides the health of the babies that are supported and hospitals that save money. A question that comes up for Professor Keller. We speak about families who should be in the hospital for better care of newborns and premature babies. But do hospitals have enough room? Are they equipped with enough space and with all the regulations they need to do that? Or is that a point that needs to be improved urgently?
Yeah, thank you for this wonderful question. Family integrated care, I think, has to take into account three different parts. The first part is the team, the philosophy of the team, the inner attitude of the team. So which means if you really want to implement family integrated care successfully, this needs the whole team implemented. We know that parents have a specific perception in this critical situation, and it's enough if one or two team members questions the meaning of breastfeeding or of other interventions. So which means we need a vision of the unit, you need a consent of the team. So this is very important. Second is we need a continuation of care from prenatally after discharge, where the interfaces are defined, where the parents get structured support, either parental coaching, by psychological support, by social co-workers. And third, this is the infrastructure. And of course, the presence of parents requires the infrastructure in the hospital. However, we cannot, and I'm quite realistic with that, we cannot just destroy all the whole old NICUs and just rebuild due to financial issues. However, in our unit, we are actually really rebuilding the completely unit, and we design maternal child unit, where the parents can stay from the day one with their preterm born infant. However, this needs financial support, which needs fundraising campaigns. And this is something where we definitely need to work on a strategic level, on a political level, because currently governments tend to finance what is medical necessary. But the knowledge that family integrated care has to be seen as a kind of medical intervention is not there. And therefore we need social marketing, not only for breastfeeding, but also family integrated care.
I have got a sign that there is another question from our worldwide audience, so I hand over to Kim again.
Great, thank you. This question comes from the web and can be answered by anyone, but maybe Professor Spatz or Professor Dennis. You might want to take this one first. It says, how can the increased involvement of parents help with the lactation and breastfeeding during the care process?
I'll start in that. At Children's Hospital of Philadelphia, we have a Center for Field Diagnosis and Treatment where the families come to us. They relocate from all over the United States and sometimes the world. More than 50% of our families come from over 100 miles away. As part of their prenatal care, we offer group prenatal care, or the centering model, which is a midwifery model of care where the fathers and the partners are involved. And one of the main focus during the prenatal period is the provision of human milk and the involvement of the partner. Now, in our case, sometimes it's not a father, sometimes it's a support person, but we actually give whoever is supporting the mother, whether it be her partner, her spouse, her mother, sister, we actually have a list of jobs, 10 steps that they are given to support the mother through their initiation of pumping and their experience during the NICU stay. So we have lots of different types of families in the United States, sometimes not traditional, and so we involve whoever is that primary support person to make sure they understand the value of supporting the mother in initiating milk supply for her baby and sustaining that through discharge.
I'll take this question from a very different stance. I'll talk about a clinical trial that we recently completed and published in Pediatrics just late last fall. It's a trial where we looked at evaluating a co-parenting intervention where we recruited over 200 couples off a postpartum floor. And while the couples were still in hospital, we educated mother and father, but particularly targeting dads, about how they can be useful and helpful with breastfeeding. So what we did is we educated him around the breastfeeding process and how to effectively find answers to difficulties that were encountered. And we talked about co-parenting, where they can work together as a team in relation to infant feeding goals. And we had Dad have a voice during that whole process, and we made sure that he felt involved. So everything was tailored towards the father. And then what we did is we provided them with access to a specific website for fathers and workbooks that were targeted for fathers. And then we discharged them to the hospital, did a couple telephone follow-ups just to make sure that they had access to these resources. And what we found is that by including fathers, we increased breastfeeding duration rates. We increased mother's satisfaction with the support that they received from the father, and we increased dad's confidence that the mother would be able to continue to breastfeed exclusively. And we weren't powered sufficiently to look at breastfeeding exclusivity, as an outcome, but we did see some positive trends in that direction. And so we think that by actively including father as to how he can be helpful in the whole breastfeeding process can have a significant impact on the family and infant feeding outcomes.
Thank you. Are there a last opportunity? Yes, a question. You get the microphone, please.
My question is about support to fathers and partners, because a lot has been said about it, and I think that my question goes to Dr. Spatz. Are there any special programs for mothers who do not have such support? For instance, very young mothers or single mothers that do not have husbands or partners or fathers that would be alongside?
Thank you for that question, and I'm really glad that you asked that, because again, in the U.S. and especially where I work, we have a lot of families that are not your traditional family structure of mother and father, and so one of the interventions we have is our GEMS group. GEMS stands for Group of Empowered Mothers, and it is a mother-to-mother peer support group for mothers of hospitalized infants. Now, this is very different than peer-to-peer support for mothers who have healthy babies, because if you want to have a mother continue to breastfeed, we know that in healthy term populations, if we have mothers spend time with other mothers who are breastfeeding, they're going to be more likely to keep doing it. But for a hospitalized infant, if you sent a mother to a peer support group out in the community, that would not be an effective strategy for her. And so oftentimes mothers in the NICU, especially a young mother or a mother who does not have a partner, she may feel like she is going through that experience alone. And so by bringing that mother together with other mothers who are dealing with the same thing, a critically ill child in the NICU, we bring our mothers together once a week. We serve them lunch, we give them tea, and it's facilitated by experienced nurses who are really there to help the mothers understand that they're all in this together, even if they don't have family support. That as another mother in the NICU, they form a supportive network. And we see this because they maintain their friendships and their connections even post-discharge. And that starts all the way in pregnancy with our Century model of prenatal care.
Thank you very much. Further questions out of the audience? I have one question regarding the fortification. How do you tell a mother that her milk is still very, very valuable, although it needs to be fortified? Isn't that a question also of self-confidence of the mother when you tell her, we need it? You may fortify it, but we need it. How do you do that?
Thank you for that question. First, fortification is nothing new. We do that already on a standard base. So we calculate with, scientific community has calculated with average contents of breast milk. It said, to make that happen for most of the babies, we take the average and then top it up. And that's how the products have been developed in the 80s and 90s and 2000. It doesn't get rid of the variation. So overall, the standard fortification is nothing new. So we tell that parent that the breast milk will be fortified. I assume in maybe 5 or 10 years we'll have a different concept and go away from cow's milk and find different ways to do it. But that in itself is nothing new. Now, specifically to say that this baby needs more and we need to top up a little bit because the milk is not rich enough in nutrients, that could cause anxiety in the mother, indeed, because she can think, oh, I'm not a good milk provider. And so it's a matter of finding the right words and it's a more psychological approach, reconfirming mom that that is nothing bad and for now we can work on fixing the problem.
And I have one question to the composition of milk. The two professors, Anna Cannon and Donna Geddes, spoke about ingredients of human milk that show the baby that it has eaten enough, if I put it simply and maybe stupid enough. can I think that babies know when they have enough food and that they will try to get more food, and that's a very natural process, and you don't have to be anxious as a mother that something goes wrong?
You're totally correct, Martin. You don't have to worry about the babies. We have many studies done in different ways that support the fact that babies take the milk they need and they want. We don't know how those signals are passed to the baby. So we can take two babies receiving the same amount of milk. One will feed frequently, the other will feed very infrequently, and most mothers are jealous of the baby that doesn't feed frequently. But a lot of the time they end up getting the same amount of fat in the milk, and they grow and they thrive and they're healthy. We know from studies that if you increase the mother's milk production, the baby doesn't care. The keg is full, but it still just has 1 pint, not 2. We've shown that if we monitor milk ejection and the milk is forced forward for the baby, 40% of the time the baby won't take it. So what we don't understand is what those molecules do, but how important they are, because they're important for us. If our leptin is low, we're awfully hungry, and my leptin's always low. So we need to understand those differences between formula-fed babies and human babies are marked when it comes to appetite control hormones. Leptin is destroyed in formula. Babies that drink formula have much higher serum levels of ghrelin. They're hungrier. So if we want to look at ways of improving the health of our babies, we need to find out what affects those components in the milk. And it could be a simple intervention with the mother with obesity, or it could be as simple as measuring the milk and confirming that it's okay. But I could talk a lot.
Yeah, thank you very much. Anna, short addition, or do we get on to the next question? Okay. We have a question from the audience here in Warsaw again.
John?
Go ahead.
Chciałam tutaj zadać pytanie pani profesor, która...
I would like to ask the question to the professor who has research on stem cells in human milk, because we always heard that stem cells are so important for preterm babies, and do they have the same spectacular effect on older infants? Can we say that human milk and stem cells that are in the human milk may have some curative properties for even adult population? Because we often heard that people suffering from cancer may actually eat human milk. There were some experiments, perhaps there is some therapy based on that, I'm not sure. But I'm just wondering, what is the situation with older infants and children, and whether we can actually take this research forward and think about more spectacular discoveries in the future also for older populations.
Thank you for this question. I'm afraid I'm going to answer in English, not in Polish. Yeah, you're very right. These stem cells do show very spectacular properties. And I will start just by mentioning a study that was done about a couple of years ago in rat babies. It was a rat model showing how stem cells can influence the survival of these babies that have necrotizing enterocolitis. And the researchers in that study used amniotic fluid stem cells. And they showed that when those rats that had necrotizing enterocolitis got these amniotic fluid stem cells, had higher survival rates. What's interesting in that study is that the researchers used some of the rats that were breastfed as a control. So there was a breastfeeding control in that study. The researchers didn't really elaborate on what breastfeeding could do for those rats with necrotizing enterocolitis. But in the graph, you could see that almost all those rat babies that got breastfed survived. And they were much more compared to those that got the amniotic fluid stem cells. So that goes to show that there is something there in breast milk, potentially the stem cells and maybe other factors that can contribute to survival and better outcomes for babies with certain very important diseases. When it comes to older babies or older infants, I would assume that it will be something similar, and especially if a baby is breastfed from early on, and the longer the baby is breastfed, my impression is that this tolerance between the mother and the baby would be even better. And therefore, later on in the baby's life, the stem cells from breast milk could provide more benefits the more the baby is breastfed. When it comes to older people, like adults, again, that's something that the stem cells could provide important benefits. It hasn't been investigated as far as I know, but it's very, very interesting, and we are planning to work towards that direction as well. And why I think it is important and that the stem cells in milk could be very important candidates for therapies in adults, it's because, first of all, these cells do not make any tumors. That's in contrast to other types of stem cells that are being investigated currently, which do make a lot of tumors when they are given to adults, such as the induced pluripotent stem cells. The stem cells in breast milk do not make tumors, so that's a very important property. Another important property of these cells is that they are able to turn into many different cell types, and potentially that is a very important property that we don't really see in any other cell type that's isolated from the adult. And they are plentiful. Breast milk has a lot of cells as a total. It's got millions to billions of cells that a breastfed baby ingests every day from mother's milk, and of those, thousands of cells are actually stem cells. So these stem cells can be isolated in big numbers from breast milk. Therefore, I think for these reasons, they could be very important later on.
So thank you very much to all of you here in the room. You will have the opportunity to ask further questions to the scientists sitting here in front of us. I want to thank Donna Geddes, Anna Cannon, Futeni Hasiotu, Maria Wilinska, Cindy Lee Dennis, Matthias Keller, Christoph Busch, Diane Spatch, and Shu Lee for her time, for their time, for the presence here. I want to tell you that tonight, or this afternoon, at 2 o'clock, we start 3 presentations on the web as well. So take the same link and you will be able to listen to the presentations of Donna Geddes, of Anna Cannon, and Futeni Hasiotu during the afternoon. That's an attempt we do for the first time in order to spread the message even further. Thank you everybody here, thank you everybody out on the screens, and I wish you a great day. Bye-bye.